welcome to Health Talk. My name is Janet Trang, and this is Claire Wilkinson. And with us, we have Dr. Gloria Wu, clinical instructor at Stanford University School of Medicine, Department of Ophthalmology. Today's topic will be diabetes and the eye. So tell us, Dr. Wu, we heard that you recently wrote a book.
Oh, I wrote a book on diabetes, diabetic retinopathy, and it's right here. And what happened was that I wrote 450 pages in 6.5 months because I was so into writing about this topic because I think it's very important because there's a diabetes epidemic right now in America. And what happens is, why did I write about diabetes in the retina? If in the eye, diabetes affects all parts of the eye, from the front part of the eye, which is the cornea, to the inside, which is the lens, which people get diabetic cataract, and to the retina, which is the inside lining of the eye. I'm a retina specialist, so as a retina specialist, we find that this part is very important because it's 350 microns, which is the diameter of 6 hairs, so it's very small. However, it's really important because when light enters into the eye, it goes to the retina. Once it hits the retina, it makes the connections to the brain. So this is both nerve tissue, the retina, and vascular tissue. And in diabetes, it affects the blood vessels. And because there's so many blood vessels making up the retina, and these are the smallest vessels in the body, we see the changes in diabetes in the eye first, in all parts of the body, because it's very hard for us to see the blood vessels inside the heart or the kidney, but we can see them inside the eye. So what happens if you take blood sugar that is normal, which is 100 milligrams per deciliter, and you put it in tissue culture of the blood vessel cells, endothelial cells, they live. However, if you take blood sugar from a diabetic patient, which is 150 milligrams per deciliter, in a same petri dish, the cells, which were originally normal, they die because the higher concentration of glucose is toxic. It's like a poison to the cells. So once you have these blood vessels, and they're, instead of being nice like little pipes, which are perfect, they have holes in them. They leak because the cells died, and the little openings leak blood. And when they leak blood, you have little dots of hemorrhage in the retina, or you have no blood going from point A to point B, no nutrients, no oxygen. And what happens, that part of the retina dies and there's loss of vision. So we have with us a slide of a normal retina where we'll see the optic nerve here, which is this nice round disc, and the nice blood vessels, and nothing else is wrong except nice retina, which is nice and orange in color. And then our next slide is one of background diabetic retinopathy, where this is the earliest stage of how it affects the eye in the retina. And you'll see dot blot hemorrhages, little red dots and little yellow deposits. And that's the blood protein leaking out into the retina. Then we have one more slide where it's background diabetic retinopathy, where it's still the early stage of diabetes. It still can be cured. You can still go back to normal vision. But instead, you have something called macular edema. So macular edema is what happens if you take the eye, and the macula is this little dip here, which is right in the center of this photograph. It's sort of a little dark. That dip gives you 20/20 vision. So instead of being nice and flat like the rug that we're standing on or the floor that we're standing on, instead it's like filled with puddles of blood, or it's muddy, or it's just thick and spongy instead of being nice and flat. Now that's macular edema because the blood vessels are leaking in the 350 micron space of the retina, in the 10 layers of the cells, so you have blood in between all those layers, and it's swollen, and so when light enters the eye, it hits that part which is swollen, it can't see. It can't hit all the cells it's supposed to hit, and therefore the connection to the brain becomes abnormal, and we interpret that as being fuzzy vision at near, that we can't see to read, or if we're looking at a street sign, there's like a center blackness missing. But most commonly when they have macular edema, you just can't see reading, that you just think you need new reading glasses. But instead, it's really your diabetes affecting your vision very early. And then we have one more slide, which is pre-proliferative, where you see blood vessels like this, but there's a round loop. So one of the blood vessels contorted itself to form a circle. That's called a venous loop, and that's totally abnormal. That means that the blood vessels, which are leaking, got so abnormal that they had to get convoluted and create a circle or more abnormalities to try to get blood products and the nutrients to the right part of the retina. And the last slide is one of proliferative diabetic retinopathy, when your blood sugar is totally out of control for several years, or you decide to binge on chocolates or bonbons all the time when your doctor tells you not to, and there is bleeding from the 12 o'clock to 6 o'clock position on this slide. This is a strip of kind of red blood. So it's just dripping in blood, because what happens is that these leaky blood vessels are full of holes. They're leaking blood, just dripping all over the eye. So it can be quite complex, but lucky for us in America, in all the European countries and modern countries where there is good medicine, nobody needs to go blind anymore. We have treatment, and most of it can be done in the office. There's laser, there's eye drops, there's pills, and of course there's controlling your blood sugar.
So what tests are out there for a patient to get to see if they have diabetes or that indicate diabetic retinopathy?
Well, usually they come to me already referred to me by an internal medicine doctor or a family practice doctor or a pediatrician, and they've done simple tests to figure that out. Now what happens is that many times they do not get a test called the hemoglobin A1C often enough, a few times a year. And that is also a fasting test done the same time as the fasting blood sugar. The fasting blood sugar tells you how you've been doing the last 24 hours, because you don't eat for 12 hours and you take the test. But the hemoglobin A1C looks at all the red blood cells and how much glucose is stuck on top of each red blood cell. So that is like a 6-month report card. So the fasting blood glucose test just tells you if you were a good girl or boy that one night, that one 24-hour period. But the hemoglobin A1C gives me a 6-month report card. Were you good for 6 months? And that's much more important for us in ophthalmology, because we can see the long-term changes, in the retina over 6 months. Because if you're bad for one day and you're perfect 365 days, nothing's going to happen to your retina. But if you're bad repeatedly, this is when you get the damage. And the other thing is that many people don't order that because they would be depressed, thinking, oh, I can't cheat and, tell my doctor I'm perfect. But what will happen is that test, the hemoglobin A1C, is really important for us as ophthalmologists and retina surgeons. In the early 90s, in the New England Journal of Medicine, which is one of the big journals in medicine, we did a diabetes complications and control trial, DCCT. And this showed that if you kept your hemoglobin A1C close to 6.0, which is normal, you never have eye complications or kidney complications in a 5-year follow-up, which is outstanding, because that's what we want for our patients, that they do not have any reason to lose vision or go towards blindness. Because once you go towards the proliferative stage, where you have that dripping blood coming from all parts of your retina, even though we can get you back to 20/20 vision, there is a lot of damage. And that means there's that type of damage in your kidney and your heart that we can't see as easily as dilating your eyes.
Now you mentioned patients being bad. Are you talking about diet and exercise? So how do these affect diabetes?
Well, I've seen many patients with diabetes, 100,000 patient visits in my lifetime taking care of diabetic patients. And what happens is that type 2 is more common, so a lot of people like grandma would come to see me, and it's very hard to change grandma's habits. We all love grandma. They're the ones who make us the turkey for Thanksgiving, the apple pie, and they're in some ways the matriarch of all our family, the glue that holds the family together, especially at holidays. And holidays are a very tough time. So grandma is well-meaning. She wants to do good, and she wants to take care of herself, but sometimes they don't realize how important it is to exercise 150 minutes a week, which comes out to 21.4 minutes a day, or 22 minutes. And there's just some simple exercises that they can do, even non-weight bearing, even if they're sitting in a wheelchair. Now, Claire, I know you were studying this in college,
I
and
was,
you were
yeah.
writing a little monograph about this.
I was at UCSB. I did study exercise and health, so I got a good platform on nutrition and the benefits of exercise. And so when I come to your clinic and I see the different patients, many of them have neuropathy or in wheelchairs, and their morale can be low, and it's hard to get the energy to exercise. So I thought maybe there was a way for them to exercise in their seats, or a way to do it in their while they're lying down, because really exercise, just to do aerobic exercise and increase your heart rate, you just have to move your large muscle groups, meaning your arms or your legs, and you can even be doing them in your chair with 1-pound weights or weights on your ankles. You could be doing your chores with these ankle weights on. It helps, just even a little bit helps. So low impact exercise is better than no exercise at all.
Now, we've been telling some of our patients about this. We got this idea from you, and we were really thrilled about it. Now, tell us a little bit. There's also ones that you can do lying in bed, because some people are bedridden.
That's true, yes. There are a lot of strengthening exercises you can do in bed that just basically use muscle contractions on your own. You can be laying in bed and be doing crunches for your stomach area, or you could be doing stretches for your legs just to get your blood moving through your muscles and help that benefits too.
Now, some of them are isometric, so they can just sit in their wheelchair, and if they do something isometric, is better than nothing.
That's true, yeah. Just contracting the muscles and using them is better than nothing at all.
And sometimes instead of having exercise bands, because maybe our patients don't have the time to buy an exercise band, they can use a towel.
That's true. They can use a towel to use as for resistance, or really any weights can be used instead of free weights. They can use a can of soup, or perhaps a water bottle that's full. Anything that weighs about 1 pound to 5 pounds will be okay.
So I think I tell my patients in my clinic that if they are overweight, that they try the American Diabetes Association diet. And the American Diabetes Association is very good in every major city. You can join for as little as $10. And they have a website, just put in American Diabetes Association. And you can join through the web, and through that you can get 24-hour, 7 days a week nutritional advice. You just ask them a question online, they'll answer you, and they do multicultural diets. So they have many people who deal with people who just want to eat a vegetarian diet, who are from southern hemisphere, like South American food or Mexican food or Chinese food or Asian food or South Asian food. And what's interesting about the Asian populations is that they're the fastest growing in the world with diabetes, and they also have something called a metabolic syndrome, where they cannot process lipid, they cannot process their cholesterol as Caucasians or the Caucasian population. And what happens is lipids breaks down into a glucose moiety particle, the carbon, hydrogen, oxygen, CHO. What happens is that becomes a sugar to the body, and again it pushes them into more diabetes. Or if they don't have diabetes, it pushes them into diabetes or a pre-diabetic state. And if they have early diabetes, it intensifies their diabetes and makes control harder. So for those people, they have to watch their lipid intake as well.
So, Dr. Wu, I also heard that diabetes can affect pregnancy. So I did a small study looking at the medical literature for the past 10 years. So I looked at the eyes of diabetic patients through pregnancy, and I found that approximately 20% of these patients actually progressed to a worse state of diabetic retinopathy during their pregnancy. Do you see this in your office?
Now, usually in my office, I get referrals from obstetricians, and what happens is that many of them have already type 1 diabetes, so they were diagnosed as a child. So by the time they're pregnant, they know they're diabetic and they need to be in good control. And what happens with the type 1 diabetic women, they are so motivated to have a good birth outcome that they're in excellent control. But what happens with the type 1 diabetic women who become pregnant, this is much better than the 1920s when diabetes was first discovered and insulin was first discovered, is that they can get a big progression of loss of vision. And usually we ask to see them every trimester or sometimes once a month. And for them, strict diet control and insulin is very important for their pregnancy. And we've been very lucky that we've be able to maintain their vision while they're pregnant. And what happens in pregnancy, the pregnancy hormones work against the pancreatic hormones of insulin, so that it's very hard for them to control. And in addition, they are having weight gain because there's actually a fetus, which is also presenting hormonal issues to how much insulin they're producing to maintain their diabetes. Now, in other patients who are type 2 diabetic, let's say they're pre-diabetic before they're pregnant, they push themselves into a diabetic state. And for these women, and there's a growing epidemic of them because there's more pre-diabetes in America than ever before, that they can have a progression of loss of vision as well, and they need to see an ophthalmologist or a retina specialist like myself. And then lastly, they have the gestational diabetic patients who are never diabetic, but during pregnancy they become diabetic because of the extra weight load, the fetus, and themselves. You know, they're not exercising, they don't feel good, sometimes they're nauseated, they just can't eat what they normally eat, and they just eat bonbons or ice cream because it's the only thing they can tolerate. And what happens, they get gestational diabetic symptoms, and they have loss of vision. Most of the time in gestational diabetes, they do not have changes that affect the retina inside here, but instead it's the lens. So what happens if they have high blood sugar, this lens gets bigger. Instead of being nice and flat like this, it becomes round like an onion and then shrinks back to this size within a day. So they will have changes, big fluctuations of vision in gestational diabetes. And a lot of times people don't bother to see an ophthalmologist, but they should, because there are changes. And sometimes the changes in their lens in the gestational diabetics continues until they finish nursing, because this lens will just get big and small within a course of a couple of days, and they can't see. So they need glasses during that time, temporary, and it goes back to normal if their diabetes is in control. And in the gestational diabetic patient, what happens is that they have a 20 to 50% chance of becoming diabetic later in their lifetime. And if they're gestationally diabetic with each pregnancy, the risk is higher. It's been reported as high as 70%, to get diabetes. So these mothers need to be seen by an ophthalmologist, because sometimes it's missed until it's too late and they have loss of vision, or that macular edema that I showed you in an earlier slide, where the retina becomes very thickened just in the macula, which gives you the 20/20 vision. So instead of seeing 20/20, they start seeing blotchy parts. They're missing the letter A in the newspaper or the letter T. They can't see it as well.
Okay, so in pregnancy, about 8% of these people actually get gestational diabetes. So for these patients, they have to be under extreme glucose control, and they have to really watch their stuff because they have future health issues.
Now, sometimes it's very hard to explain to a gestational diabetic because nobody in their family is diabetic, and they've never been diabetic, and it's poo-pooed, and says, oh, I'll be fine, because you have a certain euphoria during pregnancy anyway from the pregnancy hormones, from estrogen. But it's important to keep it in perspective. They can do the exercises that Claire would recommend, the 22 minutes a day, or some sort of exercise, even if they're lying in bed, because many times a lot of women in pregnancy, if it's a complicated pregnancy, they're at bed rest for the last trimester. So even if they are at bed rest, they should consider doing the arm weights, something. It's important.
Okay. So what would be some of the symptoms that people would get, and how would they know they would have diabetes in the eye?
Now, obviously they would have loss of vision. If it affects the cornea, they can't wear their contact lens. It hurts because they stop producing the right amount of tears. And in addition, with diabetes and the cornea becomes very thin, and once you put a contact lens over it, you rip the cornea more easily. You get a corneal abrasion, you hurt your cornea, and it's extremely painful. Other things is that, as I said, the lens becomes big and small within the course of a few hours, even within eating. Like, they'll notice they can't see after they eat, and so or they can't see for a few hours after they eat. And what happens is this becomes, instead of small and flat and oval like this, becomes round like an onion. And then lastly, they can have the changes in their retina. This is where most of the action is in diabetes, but these also occur, and this we can see very easily when we dilate a person's eye. And many places, including optometrists who sell glasses, they have photographic equipment to check this out, and they can email it to their ophthalmologist. And of course, all ophthalmologists have this type of equipment, and retina specialists definitely have it.
So what are some of the treatments that you generally do for patients with diabetic retinopathy?
So in diabetes, that affects the retina, the inside lining. If it's very early, where it's background diabetic retinopathy, where there's only like 30 microaneurysms, meaning 30 little dots of bleeding here, we tell them to see their internist and control their diet. We have something called eye drops, called non-steroidal anti-inflammatory eye drops, which we can put them, they can use, and that'll decrease the inflammation component of diabetes. Now, this is controversial. Some people do not use this. I trained in Boston where they discovered many of these eye drops, and we found that to be helpful because if you're 20/25 vision, which is 95% of normal, A minus, for using eye drops and they get to 20/20 vision, that's perfect. They're pretty happy about it. Now, once they get into the pre-proliferative stage, where they make that vascular loop you saw, where these blood vessels become fat and sausage-like, they really need tighter control because they're one step away from needing laser. Now, in between, in any of these stages, you get the macular edema. So if diabetic retinopathy, the stage is background diabetic retinopathy, pre-proliferative, and proliferative, if those are the flavors of ice cream, vanilla, chocolate, and strawberry, macular edema is the sprinkles. It can happen in any stage. So you can have swelling of the retina. Once you have swelling of the retina in any stage, even if you have 20/20 vision, usually we do a test called a fluorescein angiogram. So not only we take photographs, but we inject inside one of these veins a dye which comes out of the kidneys, is water soluble, and this has been done since 1965, 69. And what happens is that we will see indeed how many microaneurysms there are and how bad are their blood vessels leaking, because sometimes we cannot see this with the naked eye. Then they are a candidate for laser, macular edema laser treatment. And that has been proved to be very effective since 1985, when we had the early treatment diabetic retinopathy study, which was funded by the National Institute of Health, and we looked at 200,000 patients. So that is the standard of care still. And then once they're bleeding, like we saw in that picture in the slide where they're bleeding from 12 o'clock to 6 o'clock, these big drips of blood, that's called proliferative diabetic retinopathy. And for those people, they definitely need laser. However, there is a subgroup of people where we now use an injection called Avastin, which is made by Genentech, which was originally used for breast cancer and colon cancer, where we inject it intravitreally. So we inject through the eye here with a very, very tiny needle. Nobody feels it. And we inject a monoclonal antibody which blocks the production of vascular endothelial growth factor, which they think is causing this bleeding. So they think these blood cells are leaking these toxic substances, causing the growth of new blood vessels. And then that's been very helpful for people with the very severe macular edema, where's the swelling here, and the proliferative diabetic retinopathy, where they've had laser, but still they're bleeding through that. It is a tough disease once you let the disease go to the proliferative stage, because by then you've damaged enough blood vessels. There are holes on all of them. And it's just very hard for the body to heal when many, many of your blood vessels are in that kind of state where they're just filled with holes.
So for patients who are diabetic but have no vision loss, no symptoms, how often should they see someone like you, an ophthalmologist?
If they're newly diagnosed, we should probably see them because we don't know how long they've been pre-diabetic. They think that 1/3 of the diabetics in America don't even know they have diabetes. They're just walking around, urinating a lot, eating a lot of food, drinking a lot of liquid, and they just think they're fine and they think they'll just put on new reading glasses. So many times people don't even know because they get the fasting blood sugar and they've been good for that 24 hours and they don't get the hemoglobin A1C, so we don't know the 6-month report card. So we should see them when they're diagnosed because we don't know how long they've been cheating. And then we should see them if they have background diabetic retinopathy. Some people see them once or twice a year, but it depends on their blood sugar control and their cholesterol. If their cholesterol is 400, their triglycerides are 400, their hemoglobin A1C is 12 for the first time, you need to see them more than once a year because they're a time bomb, because you need to tell them that something's happening to their retina. Because once you show the patient the pictures that this is their eye, they can reverse this, they're very motivated. If you don't show them what's happening, they're not motivated to change their eating habits. And if they have more severe disease, we see them as often as 4 times a year.
Okay. So what would the typical visit encompass?
Usually they come, we take their vision, look at the E and see how well they're seeing. We check their glasses. We make them, if they're stuck at seeing 20/40, which is the driving level of vision, but they can't see 20/20, we have something called a pinhole where they look to see if they can see better. Then we check their pressure for glaucoma, because diabetes can also push them into glaucoma, because what happens is that here is the blue part of the eye, behind it's the ciliary body. If that has no blood vessels, it's not functioning. It then doesn't drain. Here's this little tiny opening, the trabecular meshwork. It won't drain the fluid in the eye, and they push into a type of glaucoma. And so we check them for glaucoma, and then we dilate them and look at their retina and see what's going on. And then we look at them with a bright light, and we sometimes take photographs. We measure the thickness of their retina using optical coherent tomography. So they're there for a minimum hour just to figure this out. If they're a new patient, probably an hour and a half.
Okay.
Now, what do you think about changing their lifestyle? Do you think that's difficult for them? What do you ladies think?
It's hard. It's really hard, because I understand that once you've been used to eating these fatty foods and your taste buds are used to it, because I know that it takes 6 months for you to change your taste buds. So for these patients, it's a huge, drastic change.
It is huge. We also even wrote a cookbook. It's on Amazon, Diabetes.
Okay, well, thank you for discussing this topic with us, Dr. Wu. I know it affects a lot of us and our family members and friends, so this information is really important to us.